I'm going to do the honors on our next portion of rounds, and we're very fortunate to have a guest today. Carleton Bulkin is our guest speaker for the second part of rounds. Carleton is a member of our iInstitute Community Action Board. He has a remarkable background. I'm going to read a bit of this because the faculty and students know, trainees know, I'm usually pretty good at memorizing people's backgrounds, but yours is so extensive, Carleton, I'm going to have to do a little reading here. So Carleton was born in Massachusetts and grew up in Northern California, and developed a talent for languages early in life. He earned his bachelor's degree in Russian language and literature from UC Davis, and then a master's degree in Slavic languages and literature from Indiana University. He was a FASCAL fellow, and then began his career in the Foreign Service office, where he initially served in Prague, and then in Havana, Moscow, Budapest, Kabul, Rabat, Jeddah, and Washington, D.C. in the U.S. And he had a remarkable career working on a number of policy issues, including human rights, religious freedom, counterterrorism, institutional development, elections, and U.S.-NATO relations, as well as doing work in optimizing staffing at overseas U.S. missions. He was elected by his colleagues to represent them on the executive board of the American Foreign Service Association, and received several State Department Meritorious and Superior Honor Awards, as well as the Sinclair Award for Achievement in Language Study. He's the author of a Dari English Dari Dictionary, and has translated a number of Czech works into English. And in his free time, of which there probably isn't much given all of that, he's an avid reader, plays classical guitar, bridge, and is a fitness enthusiast. We got to know Carleton when he came to Seattle in 2017 after he retired from the Foreign Service to be near his family and friends. He began working with a service animal for visual impairment. Carleton has Usher syndrome and is really focused on working with us to help find cures for the next generation of folks with this disorder, as well as associated retinal degenerative and sensory degeneration disorders. For today's grand rounds, Carleton approached us in the beginning of the year and asked if he could give somewhat of a patient's perspective on Usher syndrome, ophthalmology and beyond, and looking at an integrated multidisciplinary approach, including really how to work with patients for whom treatments are not optimal right now, and how we can kind of work together for building a better future. So Carleton, thank you so much for making the time this morning to speak at our rounds, and I will turn the mic over to you.
Hey, thank you very much, Dr. Van Gelder, for that kind introduction. I appreciate it very much. Just a comm check. Can you guys hear me okay?
Yes. You sound great. Audio
is great. All right. So actually, I'm very happy to be speaking to you today, to a group that's largely residents at the University of Washington. You're working in a field that I think is very exciting right now. There is some interesting research being done with respect to a range of forms of retinal degeneration, but including Usher syndrome, which is not only retinal degeneration. And I would like to challenge you a little bit today, just by sharing some of my own experience and that of my peers who also have Usher syndrome, in order to just think ahead and how we can have the best partnering relationship as medical professionals and as patients when Usher syndrome is involved. So I've got a couple slides I'd like to share with you. And if you'll bear with me, I'm going to pull those up. Here we go. So my basic idea is that Usher syndrome is a complicated condition. And even if ophthalmologists and ophthalmologic research is kind of at the forefront of where we are right now with Usher syndrome, it still involves many other things, not only medically, but also psychosocially, and in a practical sense, just through managing one's life and one's ambitions as an individual with Usher syndrome. So very briefly, just what it is, and I'm not going to dwell on this too long because I think you guys have pretty good information, you know where to find it. But Usher syndrome includes retinitis pigmentosa, which is a disorder that affects first the rods and then the cones in the retina. It first expresses itself in a patient as tunnel vision and night blindness. And those get progressively worse as time goes on because the rods are unable to renew themselves. And over time, it comes to affect the cones as well, therefore color perception. The second aspect of Usher syndrome is hearing loss. It begins usually early in life, different stages, different degrees, depending on the subtype, but it's a sensory neural hearing loss and is permanent, can't be restored. It usually leads to hearing aids being worn early in life and eventually cochlear implants for many, but that's personal choice. Lastly, Usher syndrome also can involve some balance issues, some vestibular issue, and that has to do with the workings of the inner ear. Surprisingly enough, there may be a common protein that's kind of the culprit of all of this. The protein is called usherin, and it may be common to both the cells in the retina that are affected by this condition and also to the cilia in the cochlea. So Usher syndrome is the principal genetic cause of deaf blindness globally. It seemed to be responsible for about half the cases. We need better data, but this is what we've got right now. And go forward. I'd also like to share that from what we know in the US, Usher syndrome affects 3 to 6% of all children who are born deaf, and an additional 3 to 6% of all children who are born hard of hearing. Surprisingly enough, in Washington state, and perhaps in no state in the US, is genetic testing for Usher syndrome the standard for infants who are born either deaf or hard of hearing. But this is something that I think needs to be part of the conversation going forward. And hopefully we can do that. I apologize, it seems like my screen has stuck. So I'm just going to keep talking with you and I'll try to pull it up again. But as far as what Usher syndrome is, another important thing to keep in mind is that it is inherited through an autosomal recessive pattern. So what that means is that you can develop Usher syndrome simply because you receive the gene from each of your parents, but then neither of your parents will necessarily have it. So in effect, you develop this syndrome with far-reaching implication medically and for the rest of your life, but you don't really know anybody in your family or in your immediate circle who has it. So you have no role models. And this is going to be important for you, I believe, as you work with patients who have Usher syndrome. They won't have the vocabulary to really talk about what's happening to them. And they won't have the role models to really guide them in managing the condition. So that makes your role all the more important. Well, I'm afraid my PowerPoint has kind of stuck, but we can do without that. let's see. So my next slide that I wanted to share with you kind of surveyed the different types of Usher syndrome. There are three basic types, type 1, 2, and 3. They each have their respective effect on vision, hearing, and balance. Type 1 tends to be more severe with retinitis pigmentosa, or RP, uh, affecting the patient very early, between the ages of 0 and 10. And hearing loss will probably be profound right from birth. And so these patients are very quickly candidates for cochlear implants. And moreover, patients with type 1 will have vestibular issues probably from infancy. When they are babies, it may be harder for them to learn to stay upright, just in a sitting position, and they tend to be slow to learn how to walk. Type 1F is notoriously severe among the subtypes of Usher syndrome. Type 2 is statistically more common. As Dr. Van Gelder mentioned, I have type 2A. That is the most common statistically. It's somewhat less severe. You are born with hearing loss, but that doesn't interfere with your acquisition of language because of the timing. And so you kind of go through your childhood and your adolescence, and you think that, okay, I have a hearing loss. That's my thing. I can work with that. And then in your late adolescence, you will probably discover that you don't see as well at night as your friends do. And you know, it's at that point that you may be diagnosed with retinitis pigmentosa. And this was an experience common to myself and many of my friends who are about my age. And I'm 54. But many of our ophthalmologists did not, or possibly could not, make the connection between the hearing loss and the vision loss. And they were very cautious about making any connection. They said that it would just as easy to interpret the confluence of the two conditions as coincidental. And this is changing. We'll talk about that. Let's see, the third type is a bit anomalous. When we talk about type 3 of Usher syndrome, it's less well described. I believe that there are fewer such cases, and it's a little harder to pinpoint the specific aspects of Usher type 3. And even beyond that, there are some cases that are truly anomalous for which no gene has been identified. That's a little bit more than I wanted to go into with you today on the subtypes of Usher syndrome. But if you're interested in more of these specific subtypes, the Usher Syndrome Coalition has a webpage with a science tab, and this tab offers a pretty good overview of the ongoing studies for the various subtypes of Usher syndrome. And some of it is quite interesting, but one of the points that I want to emphasize today and leave you with is that as promising as this research is, and as much as we all hope that it will succeed, the promise that it holds is really for the next generation. It is not for the current generation. Even through gene therapy or the implantation of very crude light sensing chips, we are not talking about restoring a lot of functionality for those who have already lost a lot of their cellular function. But what I'd like to focus on more with you today is really the patient experience, because this is where I believe that we can partner quite effectively if we put our minds to it. So starting from the moment of diagnosis, which is very difficult, it's my understanding that you receive practically no training as doctors in any specialty in how to present a difficult diagnosis. And moreover, you may experience a certain professional satisfaction in making a correct diagnosis that can be a little hard to let go of in the moment when you're speaking with the patient. But from a patient perspective, I want to share that a diagnosis of Usher syndrome or retinitis pigmentosa or various other conditions can be traumatic. It can lead to a kind of PTSD, really. It takes a long time to absorb this information. And it does depend in part on how it's presented, but it is a big chunk of information to absorb. It can lead to grief because as time goes on and you realize what you have lost and what you are losing, you have this overwhelming sense of loss, and you worry about what that means for your future. It can also lead to isolation, as I mentioned, because of the inheritance pattern for Usher syndrome. The individual who is living with it will really have no role models. As we patients go on with the experience of Usher syndrome, we find and we realize that it affects many areas of our lives. It can affect the educational goals that we set for ourselves, the career goals that we have, or think that we can legitimately pursue. And a lot of us stop short of what we can do. It can affect the relationship that we think are open to us. We may think that we are really not good partners for other people because of the needs that we have. And we don't know how to negotiate those needs in an equal partnership. Financial. Because a very typical reaction to a diagnosis of Usher syndrome is resistance. It's the Kubler-Ross phases. It's anger, denial, bargaining, and so on. And resistance is a big part of this. We resist because we don't want to be identified as disabled. We don't want to accept the limitation that may be ahead of us. And so we don't plan ahead financially. And that's why I have this point here. It can also affect the choices that we make on where we live and the wisdom of the choices that we ultimately make. If we get to a point where we really can't drive very well anymore, or think that we shouldn't be driving, but we live out in the suburbs, it can be very hard to get around. So in summary, the impact on the life of a person who is living with Usher syndrome are medical, but they are not only medical. They are also psychosocial, and they are very practical in their impact. And this is why I believe that a multidisciplinary approach is called for. And because of ophthalmology's position in the work on Usher syndrome, you guys are very important for this. Well, from a patient perspective, again, if we look at the current paradigm for care, we perceive certain limitations. As Dr. Van Gelder said, the treatment options are pretty limited. I don't think that that means there's nothing for us to talk about. Here's what I mean. Today, when we talk with you guys about Usher syndrome, our focus tends to be pretty exclusively medical. We're not really talking about the impact it has on our lives or some of the practical consideration that it gives rise to. In our annual consultations with you, we follow a fairly widely applied standard, which is let's measure your visual fields, probably using a Goldman test, and let's compare this year's test with the one from the year before. But I've had to move many times for my job, and that's not unique. Many of us just have to do that for our job, for education, for whatever reason. And when we change doctors with Usher syndrome, we very often hear from the new one that all these Goldman tests that you have painstakingly undergone and collected and brought to share with me for your file, I really can't use these. There's no point of comparison. And I think that that has something to do with the parameters that are chosen for the test. And I suspect that sometimes a new test will be administered without reference to the parameters of the previous one, for whatever reason. And what this means is that we really can't chart the progression of our vision loss very well. And that's really unfortunate. Uh, I think that charting gives the patient a bit of realism. Charting gives the patient a sense of being able to anticipate what comes ahead. And depending on the rest of the conversation, it might reinforce some of the positive things that the patient is doing, perhaps with your encouragement, by way of preservation strategy. There's no universal standard, and what I mean by this is that the parameters for the Goldman test and other tests just don't seem to be universally applied. A PS on this note is that at UCSF, Jackie Duncan is looking at doing some charting with patients who have Usher type 2A over a period of 4 years. And she's using a really broad range of tests. It's pretty amazing. They even include a smell test where you smell different tabs to see whether you can recognize the scents that are on offer. And her hope is that we can devise a better paradigm, I think, for charting. Unidisciplinarity. This is my last point on this slide. And what I mean by this is that we find that you guys really don't tend to talk to our audiologist or with otolaryngologist or consider the audiograms that we come up with in our other annual exams as we're fitted for hearing aids. But medically, there is some relationship and possibly some correlation between what's happening in the eyes and in the ears. And in a multidisciplinary approach, somebody would be on top of that. I think that you guys are really good candidates. On this slide, I also want to say that there's discussion of some of the promising research that is taking place for retinitis pigmentosa and also for Usher syndrome. But in terms of our conversations with you, I would urge you to be very careful on how you bring this up, because hope is not an effective emotional strategy, and it doesn't help us to manage the changes in the condition. Hoping for a cure is probably not a good strategy for somebody who has advanced Usher syndrome. We all hope for a cure for the next generation, and there may be ways to involve older patients in the research so that they contribute something. There are some areas for potential, I think, even within the current care paradigm that don't involve radical surgery. For one, genetic testing is much further along than it was 10 or 15 years ago. It is a good idea across the board, I feel strongly, for all patients with Usher syndrome to get genetic testing. Through testing, we identify just what subtype we have. We can thereby plug into research that is ongoing. We might be able to plug into some treatments that offer limited benefits to our particular subtype. And also importantly, we can connect with other people that have similar experiences. Assistive technologies are also an interesting area. No assistive technology is a cure for the challenges that Usher syndrome brings, but used in a smart way, they can extend our functionality. In the meantime, what else could we do to reduce the unidisciplinarity of the current paradigm? And I'm just thinking out loud with you guys. This is a conversation. I hope that it will be a conversation. But for one, I think that there could be a lot more focus on preservation strategy. There are studies that have been done that can be invoked. These studies have to do with the use of sunglasses, blue blockers to preserve retinal function. They have to do with nutrition and nutritional supplements. And I have had my doctors dismiss many of those studies seemingly out of hand. And in the moment, I wasn't always sure that they were fully familiar with the studies. None of these studies indicate that we can block the progress of retinitis pigmentosa or Usher syndrome using these preservation strategies, but they are something. And they also engage the patient in his or her own wellness. And I want to come back to that point at the end of the presentation today. In today's paradigm for dialogue between us as Usher syndrome patients and you guys as practitioners, I think that we could also just broaden the conversation a bit to look at some of the other resources. One place to start is genetic testing and genetic counseling. Genetic counselors have the newest national medical board in the US, as I understand. And if you look at the goals that they've set out for themselves, you find a fairly well thought out bioethic. And I think that they could partner with you very well in terms of identifying resources for patients and perhaps resources for you. So I'm going to run through this slide pretty quickly because I think that you kind of get my drift here. There are medical considerations to Usher syndrome, and we can address these together, but there are also psychosocial ones. There are a lot of things that the patient has to learn in living with Usher syndrome and managing it and coming to believe that they can manage it. But this really is important, and I wanted to make one point here that the psychosocial aspect is highly relevant because we're talking about preventing self-harm, suicide prevention. Suicide occurs at higher rates among people with disabilities, and for those with sudden onset disabilities, such as Usher syndrome, where a negative diagnosis presents itself very suddenly, this is a real risk. But the third aspect, as I've said, is practical. It's important for the patient to be able to incorporate this idea that they have Usher syndrome and that gives rise to certain exigencies. There are things they have to learn. Here is my last slide, and here is what I hope are some takeaways for you today. As you make the diagnosis, I don't think that you can simply choose the right words and avoid investing the patient with all of the baggage that many of us have found ourselves to have over Usher syndrome. But I do think that you can use the diagnosis as kind of a launching point for a partnership where you engage the patient in his or her own wellness and you present yourself as a partner in strategy to preserve functionality and to find solutions. So I think that your attitude in presenting a diagnosis is very important. If your prescription is going to be merely, well, we really can't do anything about it, but if you come in once a year, we'll do these tests. And then the patient comes in once a year and the tests don't really inform any choices that have to do with medical care or managing the condition, then that's pretty discouraging. And I don't think that that's a positive basis for our consultations. But there are other bases. The words that you use may not prevent all of the worst as far as a reaction to a diagnosis of Usher syndrome, but you can give some thought to this. Many of my friends and I who have this experience have received diagnoses from professionals who simply told us, you are going blind and you are going deaf, and nobody knows how far it's going to go. And that's devastating. There might have been some excuse for that kind of presentation in the past when we knew less than we know today about Usher syndrome. But today we know that there are many subtypes, and each of them progresses in its own way. We need better data. And that's one of the reasons that I would advocate for a better testing paradigm, whether it's the Goldmans or ERGs more often or something else, but something that measures the progress assigned to specific subtypes of Usher syndrome. But back to the point here, if you use the word blind and if you use the word deaf in making your diagnosis, it's not only unsettling, it's probably inaccurate because there are many, many degrees of visual and hearing functionality between the day when you're probably giving the diagnosis and the end of the patient's life. They will have a lot of dreams they want to pursue. They will have a lot of life that they want to live and a lot of contributions that they want to make. And they can do all these things. And you can be an essential partner in enabling them and encouraging them to do these things. That's harder if your diagnosis is too stark and present the worst case scenario right at the outset. It can be a conversation about strategy. Granted, the positive effects of that strategy may be limited and even difficult to measure, but the patient who is invested in her or his own health is probably going to do better in the long run in every aspect of their lives. And I believe that if you cast your conversation with such patients as a strategic consultation, it's better for everybody involved, including for the families, because increasingly Usher syndrome is possible to diagnose at an early age with precise genetic testing, and therefore it is the parents of young children who are also receiving this information, and they don't know what to do with it. So it's very useful and constructive to present the diagnosis in a thoughtful and strategic way that involves partnering so that the parents can also be engaged. So let's see, I apologize if I overstayed my welcome here, but I really did look forward to talking to you today. There were some things that I wanted to put out there as the start of a conversation. And I would love to continue this conversation with any of you to hear more about your experience just working clinically and about what you think some of us with these various conditions can do to help, because we'd like to. So thank you very much.
Great. Thank you, Carlton. That was really terrific. We don't hear as erudite and really as clear an explanation of the patient's perspective on this ever. And we do have our relationship with our patients is very professional, and there are certain roles that we jump into. And we appreciate your jumping out of the role of patient and really into the role of advisor for us. And I think your insights are terrific. Are there questions for Carlton? I have one. In listening to your thoughts about the interdisciplinary nature, particularly of Usher's disease, when I was a resident in St. Louis, we had a similar condition that was multifactorial and involved several specialties, and that was Marfan syndrome, which is a connective tissue genetic disorder that results in problems with the eye, problems with the heart, and other systems. And we would have twice a year, basically Marfan's Day in the clinic, where we would bring all of our Marfan's patients together. We would basically bring all the specialists who are involved in the potential care of those patients together, and we would create an environment that included, the day before the Marfan's Day, a scientific symposium that was really aimed at the patients primarily in terms of new progress in Marfan's disease, diagnostics and therapeutics. And it created an opportunity, number one, for consolidated care that was more convenient for the patients because they could see their cardiologist and their ophthalmologist on the same day. Number two, it made sure that the right expertise was in the room at the right time. Three, it allowed for ancillary support personnel, which include people like psychologists and social workers, to concentrate their activities. And from an educational perspective, it was tremendous because if you were the trainee in the clinic on that day, you got to see more Marfan's cases than you would see the entire rest of your residency. Do you think that's a paradigm that the patient would see as a beneficial thing in, for example, Usher's, if there were to be twice a year sort of Usher's Day where we try to bring our Usher's patients back for a uniform set of testing and an opportunity to see the audiologist, the ophthalmologist, the genetics counselor, potentially a social worker or others, all on the same day? Or do you think that sort of denigrates the individual by lumping them into their diagnostic category and saying, this is the day of the year that we care about Usher's disease, and the rest of the time we don't see it and we don't think about it?
I think that's an excellent question. I do think that the idea of integrating all the different disciplines somehow or other with respect to Usher's would be a tremendously positive step. It doesn't exist now. But I would like to mention in this connection that there is a slightly different paradigm. The Huntington Disease Society of America, HDSA, has a practice of recognizing centers of excellence that apply just such a multidisciplinary model, a model that looks at all these different aspects, including social work and financial planning, family estate planning, because Huntington's affects entire families. And in fact, right around the corner from you guys, UW has been recognized as such a center of excellence. So I think that might be something to explore. Uh, I don't think that having a special day is necessarily an idea to exclude, but there are sensitivities involved. Nobody wants to be a poster child, right? Yeah. But if that's the way, at least initially, that we bring together all the different disciplines, maybe that would be a useful kickoff event. But I think it would be tremendously positive to take some initiative in this regard. All the pieces are there. It's just a matter of bringing them together.
So I appreciate the thought, and what I might suggest is that we get a small group of our faculty and trainees together who are particularly interested in this domain, who have expertise in areas like genetics and potentially clinician scientists, and work with you to create an environment that works better for the patient with ushers, and use that as a model. We've been successful. I don't know if Courtney is on our Zoom this morning, but we've done a similar thing for another relatively unusual disease that requires multidisciplinary care, which is idiopathic intracranial hypertension. And the IIH clinic, which is a combination of neurology, ophthalmology, and neurosurgery, has been very successful, I think, in serving patients with that rare condition. And I would love to see that paradigm extended. I don't know that we can do it for all 6,000 ICD-10 codes that we have out there. There's a lot of diseases, but Usher's is a very special one with the sensory loss and the very stereotypic linked pathologies. So I see one other question, Raghu, and I will remind the faculty, no faculty meeting this morning because we have our retreat on Saturday, so no one's late for faculty meeting. Raghu, your question.
Yeah, that was a great talk, and obviously the perspective as the patient was a very, very important component of it. And you've touched upon the fact of genetic testing being very, very important. I'm just curious your perspective as a patient as it relates to testing across generations. In my subspecialty, I can remember one patient with a condition dominant optic atrophy where it was a father and son combination, and the perspective of the son, even though he was in his 20s, with regards to doing the genetic testing, was not ideal in the sense I think he felt that he was getting dragged into something that he didn't want to get to think about in his 20s. And it became a very long conversation within the family between the father, the mother, and the son, and me with regards to the pros and cons of doing something like the genetic testing. And ultimately, he agreed to it. And ultimately, he was positive, as was his father, for the mutation. But it took him some time to come to grips with the diagnosis and his reaction to the diagnosis. So I was just curious your perspective across generations when you see somebody who's older, and the question of the appropriateness of testing and at what age that makes sense for children for other generations.
Well, this is interesting. The Usher Syndrome Coalition, which I mentioned, has a really good website. In fact, one of the new things they're trying to do there is to look at creating sort of a model for managing Usher syndrome as one progresses through life, through the ages of man, if you will. And they suggest that for the patients who are the youngest, that it probably is the parents who will have to step up, or who are the best positioned to step up and play the role of advocate with respect to the school systems and ensuring that the person with ushers gets the best services. But then around age 14, that's when the kids can reasonably learn to begin to self-advocate a bit more. This is an important life skill. It will be a very important life skill for them going forward. And then as the kids are a bit older and they go off to school, God willing, then they'll have to come to play an even bigger role in advocating for themselves and just figuring out the solutions that are going to work for them. I would like to make one more quick note that within the HDSA, the Huntington Disease Society of America, there are some social workers who focus on youth. And they've done some tremendous work to map out the psychological impact of growing up with the specter of Huntington's disease and trying to make all of these life choices along the way. And specifically, what they found is that many of these young people feel themselves to be older than their peers. They've been sobered by some things that their peers haven't really had to think about. Certainly not in the same way. And moreover, that a lot of these young people tend to socialize with those who are older. And I think that's kind of a reflection of the same thing. So Dr. Mutumbai, I think that there is not only an intergenerational dynamic that deserves more exploration, but also an intragenerational dynamic. It's just as each of us come to grip with our personal diagnosis, we will respond in different ways with different levels of equilibrium, but the dialogue is very useful. Role models, positive role models, that's what I would say.
Thank you, Carlton. One last question. I think Jen Chow has her hand up. Jen?
Hi, that was just a wonderful talk. And I think, we all appreciate and certainly I do, the sort of ability to continue to learn by taking in perspective from our patients and certainly your guidance to heart. I did notice in terms of a question about how to initially have the meeting with the patient or the parents about their diagnosis, I find that in that process, it's almost like starting by sharing sort of a mourning process, because it's sort of mourning the loss of something that, that of a function or functions that they didn't expect to lose in their life. And so we sort of look at it as sort of I look at it sort of like as a process that we go through in sort of the beginning of a relationship. But are there just certain points that you think that would be really helpful, that first meeting when it's sort of a bit of a shock and a bit of a process just to start, that you think would be sort of key statements or key ideas to try to get across to the patient and their family?
Dr. Chow, I think that's a great observation. It absolutely is the beginning of a process of grieving and of loss. And all of us have experienced loss. We've lost, a parent or a partner. And I think that we can try to begin to think through the answer to this very important question just by reflecting on our experience. I would like to share that in New York, there is a counselor named Rebecca Alexander, and she herself has one of the, if I remember correctly, one of the more anomalous forms of Usher Syndrome, but she shares this experience with the rest of us. And one of the things that she has done in her practice is to counsel many other patients with this and similar conditions. And while her slate is full, I remember hearing her say in response to a question, well, who else can take this on? She basically recommended counselors who are skilled and experienced in the areas of grief and loss. And Dr. Chow, I don't know if that means that it would be appropriate to include such a counselor yet in the meeting where a diagnosis is delivered, or to have a quick follow-on appointment set up at the option of the patient. But as you said, it is a process.
Great.
I wish I could say more there.
Well, Carlton, again, thank you so much for bringing your perspective, your experience, and your wisdom to our rounds. I think this will be the seed of potentially a really positive project in trying to optimize our care for really the whole genetic inherited retinal degeneration community, and in particular the unique challenges that we have to Usher. So we really appreciate you bringing this forward to us. And thank you so much for taking the time this morning and for your service on our community board. This is what our board is all about, is connecting our patients, our Eye Institute and our department to our community. And you've really helped us greatly in that regard. So thank you, Carleton, and thank you to everyone who's attended this morning.